Hey everyone, this is Victor from Cyborg for Life, and today I have a very special interview for you. It's the Battle of the Nails that brings together three of the world's best limb lengthening and deformity reconstruction surgeons. Dr. Metin Kucukkaya from Istanbul, Turkey, Dr. Donghoon Lee from Seoul, South Korea, and Dr. Peter Thaller from Berlin, Germany. They're going to be exploring the development of the limb lengthening procedure and the latest advances in internal nail technology, including the FitBone, Precice, and Stryde internal nails. The Battle of the Nails represents a unique opportunity for these surgeons to collectively share their personal experience on the limb lengthening process. So without further ado, I bring you the Battle of the Nails. Hey everyone, this is Victor from Cyborg for Life, and today I want to welcome you to the Battle of the Nails, an exclusive interview with three world-class limb lengthening and reconstruction surgeons. Today we will be speaking with Dr. Peter Thaller from Berlin, Germany, Dr. Metin Kucukkaya from Istanbul, Turkey, and Dr. Donghoon Lee from Seoul, South Korea. Dr. Thaller, Dr. Donghoon Lee, and Dr. Kucukkaya, welcome to the show. How are you all doing today?
Good to meet you. Hello. I'm fine. Hope you too.
Awesome. Dr. Lee. Okay. So today we're going to go ahead and be talking about the advancements in limb lengthening technology as we delve into the world of intramedullary lengthening nails, the pros and cons of each. And we're also going to touch on each of your experiences with them and your respective practices. So I'm going to pull up a presentation here that I have, and we're just going to talk about them. So here we are. So the Battle of the Nails with Dr. Peter Thaller, Dr. Metin Kucukkaya, and Dr. Donghoon Lee. All right, so briefly, we're just going to talk about the intramedullary nail versus the external fixator. Then we're going to go over an evolution of the intramedullary nails. We're going to touch on the pros and cons. Then there was some corrosion issues with different intramedullary nails. We want to kind of get your thoughts on that. Then there's a big discussion on weight-bearing nails in the limb lengthening communities. And then finally, what's next? What's the future of limb lengthening nails look like? All right, so let's go ahead and get started. So, Dr. Thaller, I want to start with you. When it comes to an internal lengthening nail, what are the pros and cons versus using something like an external fixator in the terms of limb lengthening?
Yeah, the pros and cons are quite obvious. The external fixator is bulky. You have to wear it for a longer time than a nail because the nail will be stable all the time, stabilize the leg all the time. And you need the external fixator quite a long time for the distraction period and the consolidation period, which is quite long. There are options, lengthening of a nail and things like that, but they have quite a it's not as big, but there is an infection risk. So the nail as a central load-bearing device is the most stable of all those.
Okay, gotcha. Dr. Donghoon Lee, when it comes to a patient who has a leg length discrepancy in their tibia per se, would it be better to use an external fixator, or would you think that an intramedullary nail would do the job?
Yeah, I think it's not the matter of LLD or cosmetic. It's about the anatomical segment which we lengthen. So for the tibia, I use all lengthening methods: the lengthening nail, lengthening overnail, lengthening under nail, and X-fix only. Of course, if a patient's gross plate is still open, we can only use an X-fix maybe. But for adults, I would choose among the lengthening nail, LON and LA10. Okay. In case of tibia lengthening, there's pros and cons of each techniques. So I would determine based on the patient's condition.
Gotcha. So it really depends on the patient's condition and where you're coming at for the surgical approach. Dr. Kucukkaya, for patients who are seeking stature lengthening with either achondroplasia or if they feel like they need to boost their stature, a lot of, I'd say that limb lengthening industry, there's surgeons who are offering lengthening over nail for the femurs. Is this a good choice for a surgeon to do an external fixator on the femurs for stature lengthening, or is that not optimal?
Do you mean that for the lengthening over nail technique?
Yes.
Okay. If I use lengthening over nail technique sometimes, but not in stature lengthening, also not in achondroplasia. In achondroplasia is different. If you wait for a achondroplasia patient, their bones usually doesn't reach to enough length for insertion in lengthening nail safely. So first, they must be lengthened with external fixator and then lengthening nails.
Gotcha.
But for cosmetic lengthening, lengthening nails is always my first choice.
Okay, lengthening nails. Yeah, that's what I think
Also,
is. Yeah,
I can say this: if any discrepancy, if the deformity close to the knee joint, distraction with acute correction has no negative effect on bone healing during lengthening nails. So I can say distraction with acute correction is safe for the femur 30 degrees and for the tibia 20 degrees.
Oh, wow. That's amazing. I did not know that. Yeah. So I guess it depends on where the deformity is, where the discrepancy is. Okay. Very cool. Now, in terms of, I guess the benefits of an intramedullary nail versus an external fixator, we know that the risk for infection is much lower. Have you noticed that patients can still develop an infection with an internal nail, or is it much less likely? Dr. Lee?
Basically, yeah, in my procedure for the tibia, I always do lengthening nail, precise nail. I mean, before precise nail develop, I also did the lengthening over nail, but now I do not use the lengthening over nail anymore if patient can get the lengthening nail.
Okay.
So infection rate with the lengthening nail is zero so far. And lengthening over nail also, if we keep the right technique and right principle, we can get 0% of deep infection, but not superficial infection.
Yeah, that's incredible. Yeah. I know that, from my case, directly, I had an internal nail and I had an external fixator when I was younger, and I was so always cleaning the wound sites, the pin sites, and it was so annoying. But if you can get an internal nail, go for that. Okay. All right, moving right along here to the next slide. I wanted to talk about the evolution of the nails. And let me just put this over here to the side. So we have, over time, the internal nails have evolved in both their structure, their distraction ability, the length that they can achieve, their stability and weight-bearing capacity. So I wanted to kind of get your take, Dr. Thaller, on, starting from the ISKD, the kinetic distractor, through the Albizia, all the way to where we were a few years ago with the Stryde, but the Precice Stryde. So if you can give us your thoughts on the advancements of the nail technology.
The nail technology started much earlier with the Bliskernop nail, which was a ratchet-driven nail. I call it the tank of the lengthening nails. And then came the Albizia nail, which is also a ratchet-driven nail, but in one piece without a lever arm. And then I think then was the time of the FitBone, which was in the early 1990s, the first FitBones, which were developed in my clinic. Then was the ISKD, which was also a ratchet-driven nail, but with a much finer mechanism. And then I had quite a good experience with the first magnet-driven nail, which is the Phoenix nail, invented by Arnaud Souverain, a French engineer, quite a smart guy. He made custom nails nails from custom-made nails for me. The thickest was 18 millimeter, and the thinnest was 8 millimeters. So there was quite a variety of applications with that nail, but it had its pitfalls. And I guess then was the next was the Precice nail. And there were several generations of Precice. The first Precice nail was a modular part. Metin had the first experience, and I had my first experience soon after. There are some nails on the way, which we may talk later, the nitinol-driven nails. As you say, as you termed this event, the Battle of Nails, it's just a comparison of nails, where the winner of the battle is already known because it's the latest and the most developed nail.
Right. Absolutely. Absolutely. I think everybody kind of knows that, but no, incredible. Now, I wanted to kind of get your take on, because there are multiple nails on the market right now. For example, the derivatives of the Albizia nail, we have the Goucher nail and the Betz bone. Dr. Lee, I wanted to get your thoughts on these mechanical clicking mechanism nails and their use in limb lengthening right now.
Yeah, well, personally, I've never used these nails, but all of them seem to work in the same mechanisms, the ratchet mechanism. The benefit of this nail would be its mechanical strength, which allow weight bearing. But the biggest drawback, on the other hand, would be rotation to activate the ratchet mechanism that makes severe pain. And additionally, it can cause potential problems in terms of bone regeneration, especially in tibia. Lower healing potential. So the sharing force is not good for the bone healing, basically.
I see. That's interesting. So, Dr. Kuccukaya, you were the first to implant the Precice nail. Your use with them, you've used them for years now. From the inception of the Precice version 1 to the Precice 2.2, what have the changes been, and how useful have those changes been in the Precice technology?
Thank you for this question. First, Precice was P1, as you know. It was modular, and I did first Precice case after amount of destruction. I mean, end of the destruction, nail was broken before consolidation, and I changed the nail with solid one, and at the second or third stage, I put another Precice and lengthened her. So it was modular and not so stable.
Gotcha. It wasn't very stable. Yeah, I think that the capacity of the nail was like 25 pounds. I know for my case, it was very, very light, and it would break a lot. And I think it was in pieces. You said modular, meaning it wasn't all one segment. Is that correct?
I think the problem is if you try to compression, if you try to compression, there is a problem. During the destruction, there is no problem in P1.
Okay.
But end of the destruction, the load is too much. So it's easy to bend it or fracture the nail.
I see. It can bend or rupture. Okay. So the capacity just wasn't great enough. Okay. Very cool. And we're going to come back to the comparison, the battle, the real battle later once we get a little bit more information on these nails. But we're going to move on right now. And now I kind of talk about you, all of your experiences with these nails. And in the past years, we've noticed some corrosion issues. So first of all, Dr. Thaller, I want to start with you. You've been using the FitBone for years now. Your surgical partners over the years, and being, seeing a lot of this development of the corrosion. First of all, can you tell us what the corrosion was? What was how did it develop? And then, what were some of the implications in your cases?
The corrosion is mainly dependent on the alloy. The titanium alloy nails, they don't show corrosion, but those with a higher part of nickel or iron, they tend to corrode. And it is called fretting corrosion or crevice corrosion. It was always the same part of the nail which you can see on the slide, where the male part comes out from the female part. There are thousands of micromotions during distraction, while moving, while walking, while sleeping. There are micro movements you don't realize, and these micro movements, they damage the surface of the steel. And this is the initial part of corrosion, when this surface is damaged. And you know, the atmosphere in the body, the liquid body is quite aggressive. And this causes this corrosion, and the corrosion causes problems in the bone. You can see on the left side of this slide, you can see a MRI which was taken in the week after having removed a nail with an osteolysis. The patient had pain. I had to exchange the nail by a titanium nail later. This was another, I didn't change it. The bone was already consolidated, so I could remove the nail fully. And this MRI shows a so-called sunburst phenomenon. You see the bone, and around you see the periosteum, and you see something like a sunburst. And this is a sign in the MRI for a fast-growing subperiosteal tumor, which is similar to a malignant bone tumor. But it's not a malignant tumor. It's just a reaction, a chemical reaction to this corrosion. And all of my cases who show that corrosion, I followed them up, and those tumors remodeled again.
Gotcha. Wow. So the corrosion issue, you were basically saying those micro movements of the male and female parts of the nail during distraction can cause that, but also the harsh fluids within the body. And then it can cause osteolysis and these lytic conditions, causing the sunburst phenomenon. That's the first time I've heard that. That's incredible. And this MRI, how soon after was this MRI taken? You said 1 week or
a week?
A week.
A week later.
Wow. Okay. Now moving on here to some of your other radiographs you have. I'm not sure if blocking it, but as you can see, you said over here on the left side, right here, is this the osteolysis that you were talking about?
No, this is the distraction gap.
Okay, then it's down here. Yeah.
Yes.
Right here. Yeah, I got you. Right here, and this is a blown up version of it. We can see the, look at that. It's right here.
And you can see on the right side of this picture where your mouse is, at the edge of the bone, at the periosteum, you can see, like here, the fast-growing bone caused by this chemical irritation.
Okay. So this fast-growing bone, like hypertrophic bone, is a reaction to the corrosion.
Yes.
Wow. That's something. Okay. And did this corrosion have anything? Did it affect the motor at all, or was it only the nail at the male-female parts?
We can't tell, but there was quite an occurrence of unintended shortening in those nails. You can see the dates of that nails. There were only 1 or 2 weeks in between when they shortened by some millimeters. In fact, at that time, around the year 2000 and a few years later, the FitBone was the best nail we had.
Wow.
And we could handle these problems, if we knew about. So nowadays, according to modern medical device regulations, corrosion like this is a no-go. But for us, it was kind of acceptable because we knew about, when we learned about, and there was no better implant at the market. So I preferred to use, for example, a FitBone instead of an Albizia nail, which wasn't as good.
Yeah. Okay. Very cool. Yeah. I think this, at the time, this was the best we had in terms of nail advancement, but that's no longer the case, as we'll see soon. All right. Next up, we are talking to Dr. Donghoon Lee and his experience with the Precice Stryde nail. Dr. Lee, I want to get your thoughts on, first of all, we're kind of still talking about the corrosion issue. We know that in early 2021, I think it was just about 2 years ago now, there was a recall, a worldwide recall of the Precice Stryde nails from the company NuVasive. So if you can talk about, first of all, the recall, and then also what you saw in the Precice Stryde nail.
Yeah, in case of Stryde, it took a long time to get approval from Korea FDA. So I started using them from September 2020. But just after, the corrosion issue broke out in just 5 months later. So just after 5 months after I started Stryde, the corrosion issue broke out. So on the other hand, since corrosion issue came out at the beginning of my Stryde experience, so I was able to thoroughly observe the data, just like a prospective study. This paper is the first report of corrosion from Denmark. They reported 63% of osteolysis rate, and this is far higher than my data. One of the reasons of the difference, I think, would be the difference from the post-op rehab. I mean, I was more conservative in terms of the allowing level of activity after surgery.
I see. Gotcha. So that because of that, it was recalled in that year of 2021. I wanted to kind of look at some more of your slides that you sent in here, and we see here the same thing that Dr. Thaller saw in the FitBone. It's at the male and female parts where those micro movements happen, and I guess the harsh fluids of the body also kind of affected that. Is that pretty much what we're seeing here, the same type of thing? But we also see it at the screw holes, like these sites here. Can you explain that?
Yeah. Let me walk you through these pictures.
Okay.
The second nail shows a nail without corrosion, the clean one.
Yeah.
And the third one, shows a mild corrosion. I observed a number of mild corrosion of this level usually in femoral nail. And the fourth nail shows severe corrosion. And this level of corrosion was usually found in the case of severe pain and osteolysis in the tibia.
Okay.
And the corrosion was observed the most in the junction area and proximal part of distal interlocking screws. That two area was two most common area of corrosion happened.
I see.
That was my observation.
That was your observation, yeah. And this was because, I guess, micro movements of the screw and the nail, they were just kind of causing, okay, gotcha, those micro movements. Very cool. And it caused osteolysis. So this similar thing. And this is, now I wanted to ask you, I guess Dr. Thaller and Dr. Lee, you can kind of comment since we've spoken to you so far. We've known about the FitBone having this issue almost a decade prior with this corrosion issues, and it was the best we had on the market, as Dr. Thaller said. Would the company NuVasive not have seen this, or was it like the type of metal? Did any of that have a role in playing into why we see this corrosion issue?
Maybe I want to clear something.
Okay.
Not every corroded nail caused an osteolysis.
Okay.
And not every osteolysis caused pain. And it did not correlate to sometimes there were nails with more corrosion and less symptoms, even radiographic symptoms. This is one point. As Donghoon Lee also said, not all patients had problems with that corrosion. And the other things, we shouldn't compare unlicensed nails with licensed nails. To my knowledge, at the moment, we have only 2 licensed nails, which is the NuVasive and still the FitBone. I don't know about the current corrosion problems. All the other nails are not licensed, and I think this is also what Donghoon meant. I would not use these nails because it's a medical legal problem to apply non-licensed nails.
Gotcha.
Yeah.
Okay.
And
So
I can add something about corrosion.
Absolutely.
I have some more ideas. I am totally agree with Donghoon and Dr. Peter. Think that a lengthening nail consists of 2 implants. They have 2 telescopic parts, and always there are friction and micro movement between these 2 parts, as Peter explained. So 2 important corrosion mechanisms, crevice and phatic corrosion may play a role here. I think besides the design of nail, one important factor cause-related corrosion is the surgical technique. If surgeon, this is my idea, I want to ask Peter and also Donghoon. If the surgeon uses flexible reamers, the canal must be over-reamed for the insertion of straight nail. After starting, the lengthening nail will become more and more loose in the medulla day by day. This may increase the risk for crevice and phatic corrosion. Also, too early weight bearing and using one locking screw at the tip of the nail may cause this.
Wow, that's a
this is
really
my idea.
Yeah, that's a really interesting idea. I've never heard of that before. So even the surgical technique could have an impact on the corrosion. Being, you said the reaming of the intramedullary canal can even have an impact on that because it leaves a crevice for those micro movements to happen. Now, Dr. Lee, I'm seeing here on your slide before we move on, just like Dr. Thaller said, it says it shows here that some patients who had the corrosion had no pain, but then I hear it says that pain onset 3 months after. So the patient, you're saying here that the patient actually experienced pain 3 months after they finished the lengthening, or?
Yeah, this is just one case,
typical
case, but I haven't did my data into statistics so far, but during my recent research, I felt that most of the cases, the first pain was reported by the patient after almost always after completion of the lengthening.
Oh, okay. I see.
Yeah, and the gap interval was the 4 weeks to 6 months is quite big difference, but mostly not that far from the completion of the lengthening.
I see.
So in this patient, they developed the pain around the junction area 3 months later. Yeah,
right around here. Now, do you think that this corrosion more of a matter of time, or is it? I mean, I know these micro movements over time, but do you think that you said like usually it's after the lengthening period? The lengthening period for most people who go for 8 centimeters or whatever length that they need, if it's a discrepancy, is let's say a month and a half, 3 months. Do you think it's like right around that time that the harsh fluids of the body, the micro movements that the patient has gone through with their walker and stuff, do you think it's right around that time of 12 weeks that it just starts to occur?
I guess I'm still thinking about that.
Okay.
Can you show me the next slide?
Yeah. Sorry, I know. I'm trying to move this.
Yeah. We can discuss on this slide about that.
Yeah.
The table is the whole overall cases, the result of overall cases, and you can see there is a clear difference between the tibia and femur.
Mm-hmm.
In the case of femur, no one reported pain
Right.
and osteolysis. But when I observed, retrieved the implant, 88% were found to have minimal to mild corrosion there.
Wow.
But for the tibia, the clinically meaningful pain and osteolysis were found only in the tibia. So I think we'll be able to get the more useful information if by analyzing the various additional data. But I'm thinking the Metin said that the amount of reaming is different from femur and tibia. For me, I overream the femur only 0.5 millimeter or no, because I use a rigid reamer. And the tibia, I overream up to, I don't use a rigid reamer in the tibia, so I overream up to 1.5 millimeter.
Mm-hmm.
So that might be one reason. And another reason I'm thinking is that the period to bone consolidation, because the shearing force at the junction area, the most force, I think most of the shearing force comes during the lengthening phase until consolidation. So tibia has a longer period to the consolidation. So that might be one reason that tibia has more the problem.
I see. That is ingenious. I never thought of it like that. And I have never heard any other surgeon who I've had on my show talk about that, because of the tibia taking a little longer to consolidate than the femur. Also, the reaming of the femur is a little bit greater for most surgeons. And then just the length of time. And also, do you think that because the tibia is below the knee, there's more movement? Do you think also that could be a case, or not so much? Dr. Thaller, you want to comment on that?
Yes, I totally agree with Donghoon, and I learned today again. It's all about stability. What Metin said before, what Donghoon said now, it's all about stability. It is easy for a surgeon to insert a short and thin nail into a bone.
Mm-hmm.
But it takes a lot of experience and knowledge and special instruments to really fit the bone to the nail, only overream 0.5 millimeter, and a thick and long nail naturally gives much more stability than a thin and short nail. So I see so many x-rays from foreign countries, also from Germany, where surgeons insert short nails in big femurs.
Mm-hmm.
That's not a challenge to us. It's a no-go.
Right.
And it's all about stability.
Okay.
The success, the bone formation, corrosion, and all this is only about stability. This means as you may know, the femur is bent externally and even more bent internally. And also the tibia is bent. The tibia is straight externally, but bent to the posterior internally, because the shin bone in the midshaft is thicker than in the proximal and distal part. So both bones are bent inside, and we have to provide a medullary canal to get a stable fit of our nails.
Okay.
And again, all about stability and technique.
I see. Wow. That's what Dr. Kucukkaya said earlier. He said it's about the reaming technique that can matter. And that goes with the surgeon skill. And, there's unfortunately a lot of surgeons who don't know. They just ream the bone, put a nail in. And like you said, they just slap a nail in there, but they don't think long-term there. Very cool. Okay. So we're going to move on here to Dr. Kucukkaya with the first precise nail. Man, this is he made history. So Dr. Kucukkaya, I wanted to talk about your experience over the years with the different nails, as we can see in the slide here, you had the ISKD between the 2006, 2008, FitBone 2008 through 2010, and then the Precice nail. You were the first to implant this in a clinical case with a patient. So can you talk about how, I guess, groundbreaking, revolutionary was the Precice nail compared to the other nails, the ISKD and the FitBone predecessors?
Because FitBone has a cable system and antenna, subcutaneous antenna. It was not easy to always to place in good position. Precice has no antenna at that time. It was a new thing for me at that time. Also, different sizes has Precice at that time. It was good. It was interesting for me again. So it was worked. So these are the new things in 2010.
Yeah, but they make a big difference, because I know that I with the ERC, the external remote control, all you have to do is press a button, let it go for about a minute, and you get your distraction of a third to a quarter of a millimeter, which is incredible. It's just like that technology of the magnetism. Now, the Precice nail, we know, has had several reiterations, the Precice 1 to the Precice 2 to the Precice 2.2. What were some of those changes that you saw along the way? Were they just the structure of the nail, the weight-bearing capacity? Could you talk a little bit about that?
First, I want to say, actually, I haven't used Stryde nail. So, because I never let the patient weight bear during the period. I was involved with a team of surgeons headed by Dr. Stryde on developing the design. We started working together before 2010. At that time, we worked for design the nails for retrograde femur and antegrade femur. And then there is no too much differences now, I know. Years ago, Peter also don't know about this. I saw a screw hole design difference in the surgery. For example, if you use retrograde femur, looking screw was anterior to posterior direction. So it was not good. And then I think they changed the nail design again.
They changed the nail. And so that's probably it. So small micro changes of the nail. Dr. Lee, can you talk a little bit about some changes that because you did use the Stryde nail. So can we talk about the differences between the do the battle between the 2.2 and the Stryde? If you can compare and contrast some of those differences.
Yeah, the biggest difference is the material. The weight-bearing ability is the biggest difference, and that is the weight bear. The patient care weight bearing is very attractive point to the patient, but even though corrosion is not appeared, too much strong nail can interfere the bone healing. I think it was my not I didn't statistics, but kind of my gut feeling from the Stryde nail. It showed a little bit slow bone healing than Precice nail. So I think the weight bearing, aside of weight bearing, most of the characteristics of nail, I think Precice has more strength than Stryde, I think.
Okay, it has more strength. That's amazing. Now, Dr. Kuccukaya, going back to this first case that you implanted the Precice nail in, June of 2011. In fact, my surgery was July of 2012, so it was only a year later. So I was not far off. But but looking at this case here, this patient had a 12-centimeter leg length discrepancy, and it was a femoral discrepancy. Now, did you mention earlier that the nail actually had a bend or a break, and you had to replace the nail? Is that what you said?
Yes, P2, I first used P2, P1 nail.
P1.
Yes, it was, I remember, 6.5 centimeter stroke. So maximum lengthening distraction amount is 6.5. I used first P1. End of the distraction period, the nail was bent before consolidation and before weight bearing also. And then I removed the first nail and insert trauma nail, solid nail. And later, after bone healing, I used second precise nail and lengthened her until 12 centimeters.
See, gotcha. Okay, so it was because it was only 6.5 distraction stroke, so you had to break it up in two parts. That's interesting. That's really interesting.
What was interesting at that time was the engineer asked me if I could find a patient who spoke English to understand how the patient would feel during distraction, because it was new for us also.
Right. It was very new for you. Yeah. It was groundbreaking technology. I know that my surgeon in particular, she was very taken aback. She's like, this is the best thing on the market. She's like, do it. All right. All right. Moving along here. And now we do want to talk more about the weight bearing nail capacity. And then we're going to do more of an overall battle. Even though, like Dr. Thaller said, we kind of know who's going to win. But patients are talking, there's a lot of discussion going on about weight bearing nail. For both discrepancy and stature cases. A lot of patients want to have that independence and that freedom during the distraction. But Dr. Donghoon Lee just said, he said that if the capacity of the nail is too great, it could impact or impede the bone healing a little bit. So I wanted to start with you, Dr. Thaller. Is weight bearing a good thing or a bad thing for limb lengthening patients?
Weight bearing itself is a good thing. And as Donghoon said, it is a thin line between enough stability and too much stability, because we think, it was also my experience, I didn't have so much strides. I think the strides had a bit less bone formation, was slower, bone formation was slower, there was bone formation. And Donghoon has more experience. So as we know from the biomechanics of bone healing, if it's total stiffness in plating, for example, we miss sometimes bone healing and we risk pseudarthrosis in trauma surgery.
Wow.
So thin line again to between stable enough for full weight bearing and too stable, which might mean a lack of bone formation. But I think we should emphasize the former topic. What was the major advantage? What was groundbreaking in the Precice? Donghoon and Nitti know, but they didn't tell because it's obvious for us, is the magnetic mechanism, which was the first mechanism to allow shortening. So more and more, I'm proud for this mechanism for bone transport, self-speaking, but also for lengthening of long distances. I use it if patients get in trouble with contractures, I just shorten easily. In 10 minutes, it's a centimeter shorter, or in 15 minutes. And then the contraction is solved, and then we can re-lengthen again. So the Precice, but also the Phoenix nail were the first who allowed us to do controlled shortening and re-lengthening as we want.
That's very interesting. Dr. Donghoon Lee, did you notice that for patients who had, let's say, slower bone healing, like Dr. Thaller said, that reversing the lengthening, what was like, I've heard some surgeons say the accordion technique. I know Dr. Paley speaks about this a lot of reversing and re-lengthening. What does that do for bone healing? How does that stimulate bone healing?
Yeah, we have several techniques to enhance bone healing. My first step for that is slowing the rate.
Okay,
that's the first step. And even though the bone healing is not that good, I shorten and lengthen. That's kind of the very common technique, the Elizarov technique. And then during the consolidation phase, if the bone healing is not so good during consolidation phase, we can use the lipus or I prefer the subcutaneous injection.
Got you, to help
Forsteo.
the bone.
Yeah, Forsteo usually works.
Forsteo usually works. Now, I know we want to talk mostly about the licensed nails, but I do want to kind of make a point here to kind of compare it to those mechanical nails. Dr. Thaller, you said that earlier that, you know, it's important to be able to reverse these nails in case you get into trouble or there's a patient who has a delayed union. But most mechanical nails don't have that ability to reverse lengthen. Is that correct?
Yes, that's correct.
Yeah. So
there is an appearing nail where I can't tell too much details, but there might be a chance of a reversing nail by a ratcheting mechanism and a nitinol mechanism combined. But to my knowledge, there is no ratcheting nail which was able for controlled shortening.
Gotcha. And can the FitBone reverse lengthen? I'm not completely sure.
They claim now that they can. I used a FitBone 2 years ago when there was a patient which really wanted the lengthening, and there was a short period where the Precice was also not available. So I did, after more than 1,000 FitBones, I did again a FitBone after 10 years after. There is an option now. At that time, when I did all those FitBones, you had to explant the receiver, the subcutaneous receiver, change the pose, and then you could shorten. So this is not a simple procedure. You need a surgery. I can't tell about the status now. It seems to be possible, but it's as I said. There are other problems now. There
are other problems, yeah, definitely. Now, Dr. Kuccukaya, when it comes to distracting, I know Dr. Lee said that he would slow down the distraction rate to prevent delayed unions, but does that also help out with patients? Because I've talked to a few patients recently that they are doing lengthening, and they're saying that they get nerve pain. And would this be due to distracting too quickly, or would that be just, you know, some patients get nerve pain and they have to deal with it?
You mean after distraction?
Yeah, during distraction, during the lengthening phase.
Actually, I do like this. I start a very small amount of distraction. First, I see the bone healing, because it depends on the patient to patients. And then speed it the distraction. So in all cases, I see how the bone is healed, bone capacity, and then decide this. I don't trust compression, accordion technique. I don't trust them.
Okay.
A weight break also important, of course important, but I want to say this: this is important in external fixator because we can arrange the stability. I call this dynamic stability in external fixator, but we cannot control stability in the lengthening nails. So it's not good in all cases to full weight bearing. We must choose the patient. Some patients can, it's good for bone healing. In some patients, it's not.
Mm.
So it's dangerous to weight bear in the lengthening nails.
I see. And that's even with a weight bearing nail, like the Stryde, even though it can handle maximum capacity, you're saying it's still a little risky. They need to have walking assistance.
Yes, because we need the dynamic stability.
I see.
So we cannot arrange the stability in lengthening nails. Also,
Okay.
Donghoon explained this. It's a standard.
Mm-hmm. Yeah. Okay. Very cool. So going back here to our weight bearing capacity, weight bearing nail discussion, Donghoon, Dr. Donghoon Lee. So when patients have a weight bearing nail, was their walking gait able to normalize a lot faster than when they didn't have that because they were naturally using the muscles and keeping a lot more range of motion during the lengthening phase than if they had the Precice nail?
You mean the
So-
strength of weight bearing nail?
Yeah, so like basically getting back their walking gait, like a normal walking gait, not feeling super stiff. Was it a little bit easier for patients who had the Stryde nail versus the Precice because the muscles were being used more?
Yes, right. So during the lengthening phase and until consolidation completed, the walking is one of important factor to maintain our muscle strength and to prevent disuse osteoporosis of the whole bone. So
Yeah. So
when I use the Stryde for my patient, I allow the weight bearing, but not for usual daily activity. I recommend the use crutch or walker ambulation. So, but even so, that amount of walking helped the faster muscle recovery.
okay, that's exactly what most patients want to hear. They just want to feel like the nail won't go, it won't give out, and they want to feel like they can get 2 months faster walking gait, normalization. All right, so that's a really good synopsis on the weight bearing nail. We wanted to kind of dive in here a little bit more on the FitBone and the Precice, I think, because they're both still being used. Orthofix has it. So, Dr. Thaller, having been the surgeon who used a tremendous amount of bone in their clinical cases, would you say that the FitBone has any benefit over the Precice nail, or do you think that the Precice nail is just a clear winner in a limb lengthening case?
Concerning the lengthening nails, I don't see any benefit. The Precice is thinner. You have thinner nails available. In terms of length, there are some very short, have been some very short FitBones, but that's not much around. The main advantage is no corrosion of the Precice, and the controlled shortening and lengthening. The nail is very reliable. We have so much experience now, and very important, the FitBone was always limited to specially educated surgeons. I've educated surgeons around the world to use the FitBone. The Precice nail is open to any surgeon who wants to try it. And this means that there is a bias in complications on the side of the FitBone because it was a very protected atmosphere and a very limited amount of surgeons who were allowed to get a FitBone. It was never freely available.
Interesting. Wow. I did Wow. So it was only to a select amount of surgeons who could use that. They had to be trained on how to use it because it does have different mechanisms and devices structured to it than the Precice nail. Very interesting. I didn't know that. Because I know right now, and I guess that brings up my question of is like with the Precice being, this powerhouse nail, it's like the, revolutionary nail, essentially. It's like the surgeon's dream nail. Is there any comparison to things like the FitBone, or let's say the Albizia derivatives, like the mechanical nails? Like, would you just use the Precice nail 100% of the time? You could start with you. Yeah.
If you ask me, I would, because of the medical legal issues.
Okay.
Yeah.
And then Dr. Donghoon Lee, would you also use the Precice nail over all the other nails here listed?
Yes, for now, Precice is most reliable nail, I think. And the three most important prerequisites in lengthening nails are precise rate control, mechanical stability, and biological stability. And I think Precice 2.3, you said 2.2 is not important, satisfies all of these factors, I think.
Okay, it has all of those factors. Okay, and then Dr. Kuccukaya, would you also, being the first who've implanted the first Precice to now the 2.3, would you also pick the Precice nail as your go-to nail for limb lengthening?
Yes, I would use Precice nails.
Okay, there it is. We've declared our winner. So that is the battle of the nails, but we're going to go now to the future of intramedullary nails. So I'm just going to skip back to that slide. We'll clip it here. All right, so here we are with the future of intramedullary nails, and I wanted to kind of get each of your takes on, first and foremost, patients always ask me all the time, like, are there any new nails coming out to the market? Like, I'm always that guy that takes the heat from the patients. So I guess we can start with you, Dr. Kuccukaya, because we know that all three of you have been involved in this, but Dr. Kuccukaya specifically, with the Synoste nail system. So I know that you guys are probably behind NDAs and stuff like that. You can't talk so much, but if there's any surface level information that you can tell us about this nail, or would it compare to the Precice nail? Is it going to come out? Things like that.
First of all, I like this picture. It's from our second cadaver lab.
Okay.
It was there. We were together.
Yes.
I can speak a little bit about Synoste and Nitti. I was involved in the clinical trial to show the technology is suitable for limb lengthening. I can say all patients were successfully treated and study still being completed. We will be publishing in the results, so I will not share too more details for now.
Okay, that's fine, but that's good to know. That's good to know that all the patients had good results. Okay, so that's possible new nails coming to the market. Now, Dr. Thaller, I wanted to ask you, if you could have a dream nail, like what features or new technology would you add to it? Let's say if you had the Precice nail right now, as a surgeon, world-class surgeon, what would you add to the Precice nail to make it better?
There is one thing which is, to my estimation, unsolvable. This is the size.
The size.
Sometimes I would wish a thinner nail. Yeah, still stable, but this is impossible. This is technically impossible. If I had a fully weight bearable nail, which is highly stable, and this is, I don't patent this idea, which I announce now. Maybe we could insert a strong feather, a strong, what do you call it? Not feather, a spring.
Oh, okay. Yeah.
A very strong spring to have a stable nail, which is solid and allows a little bit more of micro movements in the distraction gap. Something like this.
Okay.
Or electronically controlled back and forth games or whatever, to to get rid of this disadvantage of high stability in terms of a lack of bone formation.
Mhm.
But size would be the first wish. We have a thinner nail, which I think is really limited to the thinnest Phoenix nail I was told was 7 millimeters.
Mhm.
This is because this magnetic mechanism doesn't take much of space inside of the nail, but still it costs stability, and I think this a little bit more than 8 millimeters of this smallest Precice is quite good already.
Okay, you think that's like the minimum? Yeah, and I know that you published research on the Phoenix nail, FitBone, and comparing the Precice, and your results kind of really favored the Precice nail in the terms of the stability, which is really important, and as Donghoon Lee said as well. Dr. Lee, what would you say? What would you add to the Precice nail, or the current winner of this battle of nails? What technology or advancements would you put into it to make it better?
If I could get only one improvement with that, what I want the most is, like Peter said, mechanically stronger 8.5 nail.
Okay.
Because our East Asian has tend to have the narrow the medullary canal, so it's very problematic.
Okay, gotcha.
Yeah, and one more thing,
Mhm.
we have to develop a nail especially designed for humerus nail. I think.
Mm-hmm. They are developing that, you said?
I don't think so. I'm not sure.
Oh, no. Dr. Thaller, you're shaking no?
To my knowledge, not. With my humery, I haven't had problems to use different variations of the Precice nails, but there would be some ideas to have an optimum designed humerus nail.
So they use the
not
same.
so high. So I can understand that the company avoids licensing of such a nail NNN.
I see. So currently they use the same Precice nail that you would use in your leg. It's the same design. Oh, okay. Very cool. Dr. Kuccukaya.
I want to say my dream. Shape memory alloy, which has no mechanism inside.
Ah. So
and this is my dream.
Your dream. Yeah, I'm sorry. I'm so sorry. I skipped. Yeah. So your dream for the nail, what type of alloy?
Shape memory alloy.
Oh, a shape memory alloy. Interesting. What benefit would that bring to the nail, your dream nail?
So if they doesn't have mechanism inside, just alloy.
Oh, wow.
So this is my dream.
That I see. No mechanism, no magnetic mechanism, just automatically. That would be a dream nail.
I think it's possible in near future.
Do you? Interesting. Okay. I like that. That's exciting for me to know. Very cool. All right. I want to go to Dr. Lee and then Dr. Kuccukaya for the next two topics here. Dr. Lee, we know that limb lengthening technology is very expensive, very pricey. A lot of patients are, very unhappy with the cost of the nails. If a new nail came out, right? Let's say that a new nail came out and it was either had more features, better features than the current Precice nail, would that affect the cost of the nails on the market?
Well, I'm not sure about that, but competition between the company is basically important to lower the cost.
Mm-hmm.
Yeah.
Okay. All right. Yeah. So that's the thing. And then Dr. Kuccukaya, I wanted to talk about plating for adults. Now we know that the NuVasive came out with the Precice plate for pediatric patients, people who are youth and they're not super heavy and their bones are smaller, where they typically can't go through the epiphysis because of the growth plates. So would there be any possibility for a plate strong enough for stability for lengthening so that you could replace an intramedullary nail?
It may be for pediatrics only.
Just Yeah. Okay. Just for pediatrics. And do you, Dr. Thaller or Dr. Lee, do you have anything to comment on that? Would there be maybe 2 plates, or is it just too much? It's now gone from minimally invasive to more invasive. Is that your thoughts on that?
Metin,
Yeah.
I can tell. So the biggest incision for a retrograde lengthening is like this,
Okay.
less than 2 centimeters. Just imagine this in a plating technique.
Wow.
Even if you do the so-called MIPO, minimal invasive plating technique, I think and 2 plates is not an option, especially on the femur, because of the anatomy. So the nail is still the most stable implant because it's in the center of the load.
Okay. Okay.
And the nail, a plate will always be eccentric loaded, unless you do 2 plates. So a nail is always the best option because it's in the center of the load.
I see. Now, Dr. Lee, if let's say that during, let's say, the removal of a nail, which probably wouldn't happen in your cases, but let's say another surgeon, if there's still weak bone regenerate or the patient notices, there's not enough, there's only 3 cortices of the bone, would a plate come in handy then for an adult to kind of stabilize the side with weaker cortices, cortical bone?
You mean in case of weak bone regenerate?
Yeah, to prevent a future fracture.
Yes, basically I remove the nails when the remodeling of the bone is completed.
Okay.
Usually it takes 2 years after surgery for the tibia. I wait until full remodeling is completed.
Gotcha. Before you remove the nail. Okay. Now, the final, I guess, futuristic technology I wanted to kind of get your guys' take on is 3D printing of bone. I know that a company, I think they're a Dutch company called Ossiform, in the next, I think this year they're coming out with something, but next year, 2024, they're releasing their P3D patient-specific bone scaffold to use for bone grafting. It's beta tricalcium phosphate, and I know that's used in bone grafting now. However, theirs can osseointegrate very well into the bone and remodel it. Vascularizes very, very nicely. What are your thoughts on that for let's say the bone transport surgeries that you have to perform, bone defect patients? Do you think that technology like this will be groundbreaking? Because apparently, according to their information and their platform, they do think so. Dr. Thaller?
There are so many projects already with scaffolds. And I have rarely seen, I follow this since about 10 years. And there are bioresorbable scaffolds. The best ossification which I saw was my friend Kevin Tedsworth in Australia. He did titanium cages, but this titanium lasts forever. So I'm strongly convinced that distraction osteogenesis gives the best regenerate. It lasts longer, but it is worth the time. Okay. We have a project, we published 2 papers already on this, which we call radial fibula distraction. So we do a distraction osteosynthesis with the fibula, split it so that it can bear a nail later. This is a new technology which we didn't use in human already, but 2 papers are out, and we have animal tests done already. But I think those scaffolds, I have never seen a picture with a good remodeling on a long defect. If you have short defects, you don't have a problem. You can solve it in several techniques. But a long defect which starts at 4 centimeters and can be 12 remodeling in a scaffold technique.
Okay. All right. Well, that's very interesting to know. I'll still send you guys their links. You can take a look at it. I'll send you their website link. I think it's still interesting technology, but maybe I'm not completely explaining it perfectly well. But all right. So lastly here, we're going to move on to kind of just a fun little aspect I put in here to kind of, make you guys a little bit relatable to the patients. They love to kind of get a little bit, know you guys a little bit better. So I'm going to kind of do like a kind of a quick fire question and answer here with you, Dr. Thaller, to start. Then we'll go through Dr. Donghoon Lee and Dr. Metin Kucukkaya. So FitBone or Precice nail?
The answer is given already.
Yeah.
It's the Precice nail.
Yeah. Okay. How tall are you?
I was 189, but I think I'm 187 only now. Growing older.
Yeah, older. Yeah. All right. Now I want you to tell this story because you told me off record when we first met a year ago, the story of you versus Paley in Israel when you were giving the symposium presentation. And yeah, if you want to kind of go on to that, I think patients would love to hear that.
I told you off records.
Yeah, it wasn't in the interview, unfortunately.
But I think Dror would be okay with that. So I think it was in 2004 in Israel, in Haifa. There was the Asami meeting, and Dror was there to give six lectures on the ISKD nail, which was new at that time. And I had 3 lectures on the FitBone, and it was kind of a battle of nails too at that time. My talks were in the afternoon. Dror's talks were in the first part of the meeting. Mm-hmm. And when Dror started his first, Dror is a very smart guy. He speaks 6 or 7 languages. I really admire him. And he was already famous at that time. And he started his lecture with the question, Peter, would you mind if I give my lectures in Hebrew? And so I was out of any discussion for the rest of the meeting.
It was the language barrier. Yeah.
Yeah, I think it was good because, it was the Israel meeting and Hebrew is their language.
Yeah, definitely. I thought that was very funny. I think patients will find that funny as well. Dr. Thaller, what is a high-speed office?
High-speed office is my daily, weekly experience when I take the bullet train to and from Berlin. This is for me 3.5 to 4 hours undisturbed, precious time with a speed at a maximum of 300 kilometers per hour. And I enjoy those rides still because I'm really undisturbed. I can do all my office work. And this is my high-speed office. Yeah.
I love it. What is your favorite food?
There's so many. There's so many all over the world. I'm happy to live in the center of Europe, where we can enjoy the French, Italian, Spanish, Austrian food, German food. But I also enjoy Asian and Arabic food. A lot of those foreign things I get acquainted by my fellows from all over the world. I have visited Donghoon and he has invited me to a really several delicious meals again this September, last September. And my Arabic fellows, they take me to Arabic restaurants, and the Malaysian fellow who recently left after half a year with us. So I like so much kinds of food, and I like to taste new food and have new experience.
That's awesome. The surgeon food connoisseur. Love it. Okay, so going back to the question about limb lengthening here, what is your advice to prospective patients? Because that's who we're going to be showing this interview to. People who are thinking about lengthening for their discrepancies, deformities, and or stature lengthening.
So the most important advice is, I think, get informed and always have a second opinion by another expert.
Okay.
I send my patients, this is my recommendation to my patients. When I give my recommendation, what to do, my treatment plan, I tell them, please take the chance take a second opinion.
Mhm.
And this is especially it's important for all patients in every kind. I tell my patients, if you buy a new TV, you go to the internet, you compare prices, you compare size, and you compare everything. But if you get a surgery, you rely on the first you meet. So always take a second opinion.
Okay, that's a good piece of advice. All right, and the final question is, how do you relax? So what do you like to do on your leisure time?
At the moment, I'm planning the ski weekend, the next
nice.
weekend. Yes, I love to be outside, climbing, hiking, skiing, snowboarding.
Snowboarding.
And sometimes there is also leisure time in front of the TV.
Oh, inside the TV, just lay back and relax. I love it. And also, I know you spoke about swimming when you went to Dr. Donghoon Lee's clinic. I'm in his hydrotherapy pool.
Yeah, you have some insider information.
Yeah. Very cool.
Yes, I like swimming.
Swimming too. Swimming's great. It's a really good form of
Yes.
exercise.
Yes.
All right, Dr. Metin Kucukkaya. All right, so we're going to do some questions here, kind of fun questions, but a few limb lengthening questions as well. You kind of actually mentioned this one earlier, so we could skip over. It's about your thoughts on limb lengthening over nail in the femurs. You said that you weren't liking it for limb lengthening. But let's talk about antegrade or retrograde if you're doing a lengthening procedure.
Actually, I do lengthen over nail in femur, but
Oh, you do?
usually I prefer retrograde technique.
Retrograde. Okay, very interesting.
Technique, because you can correct the deformity. It's technically safe because easy to provide parallel orientation between external fixator and intramedullary nail, and less pin side problems. Okay,
very interesting. Okay. The next question is, how tall are you?
184, I think.
184. Okay, so just up there. What's your favorite food, Dr. Kuccukaya?
Proteins.
Protein? Okay.
Yes, steak.
So meats and things like that. Yeah, I like to eat a lot myself, work them up. All right. Would you prefer, when you're using an external fixator, let's say for a tibial deformity discrepancy, would you prefer a Taylor spatial frame, Ilizarov ring fixator, or a monolateral external fixator?
Mostly Taylor spatial frame, but in some situation, Ilizarov.
Ilizarov. Okay, very cool. Favorite beverage out of coffee, tea, or both?
Coffee.
Coffee. Got to stay alert. How do you spend your free time?
In Istanbul, usually go to gym.
The gym. That's right. Maybe I can work out with you. All right. And then what is your advice to prospective limb lengthening patients who are considering limb lengthening for either the deformity, discrepancy, or stature?
I would advise to the patients first, choose your doctor, not the surgical technique.
Okay. Very, very good. That's a great, yeah, I think it should be based on the surgeon and their results. And I think you three are literally the three best. All right. So we're going to go into Dr. Donghoon Lee. All right. Dr. Lee, what are your thoughts on limb proportions, primarily in the legs after, let's say, a stature lengthening case?
People are born with different proportions, and average proportion also differ by race. If a patient has a relatively shorter bone before surgery, it would be better to lengthen that segment in terms of proportions. One of most prevalent prejudice people have is that it won't look good appearance-wise if you lengthen the femur. But from my experience, it actually is not. And femoral lengthening has a higher recovery potential in terms of sports ability. So basically, we should consider pros and cons of each femoral or tibial lengthening and the patient desire accordingly. So careful pre-op evaluation is important, I think.
That's interesting. So basically from the aesthetic cosmetic portion, and you said also from the physical recovery aspect, the femur tends to be more favorable. Okay. When it comes to the post-operative rehab, would you prefer, or what's a better modality of recovery? Would it be hydrotherapy or anti-gravity Ultra-G treadmill?
Yeah, the hardest part about your lengthening is that you cannot stand up and you cannot move around during treatment, and that can lead to mental or muscle or bone weakness. So hydrotherapy is a very highly effective way to solve these problems. So once you try hydrotherapy, you will never go back.
Then I guess I have to come to your pool as well. All right. Dr. Lee, how tall are you?
182 until last year, but I got 183 at this year of medical checkup, so I think I'm still growing up.
We got to figure out his secret. How is he still growing? All right. How do you like to relax? Like, what do you like to?
I like sports such as cycling and running, but I haven't been able to work out so much for the past several years. So my New Year's resolution is to regain my sports ability.
That's awesome. That's a good resolution. I put this one in here. A fun. What's your favorite, cake, ice cream, or both?
Both simultaneously.
Simultaneously. I know. I do it. It's on the same spoon. What's your favorite sports team?
My sports team. Actually, I do not watch the sports game. Yeah.
Okay, gotcha. Okay, and then what's your advice to prospective limb lengthening patients who are coming for discrepancy fixes or stature lengthening?
Yeah, which nail to use, which segment to lengthen, and which surgical method. All of these are the things the surgeons and patients should find the best options together. But for the patient, key is to find the right doctor. And especially cosmetic lengthening, I advise the patient not to be too greedy with his lengthening target, since too much lengthening may threaten the recovery of sports ability and healthy joint in the long term.
That's fantastic advice. Awesome. I love it. All right, there they are, the legendary 3 limb lengthening surgeons. What a battle that was. Not only did we declare a clear winner in the internal nail category, but we heard it from 3 of the world's best in the business. If you're interested in reaching out to Dr. Thaller, Dr. Lee, or Dr. Kuccukaya for a consultation, you can find all of their contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.